We've got now just a little bit, just a bit more than 3/4 of an hour until lunch, and two really interesting sessions to come as well to look at some particular examples and really kind of going from that kind of broad perspective that we've had to some specific approaches to supporting people's mental health and well-being that I think speak really well to what we've heard earlier about some of the challenges that we're all facing. So again, not much faffing from me. Straight over to our first speaker, who is Sarah Baitup from IESO. And I will hand you the floor. It's all yours.
Thank you, Andy. So good afternoon, everyone. It's a great pleasure to be here with you this afternoon. I'm going to present two important questions. One is, have the recovery rates for common mental health disorders such as anxiety and depression, have they stagnated? Are we not able to push above 50 or 60%? And the second question is, has CBT lost its effectiveness? As some of you may have seen in The Guardian fairly recently, an article that argued that CBT had lost its effectiveness. They argued that when CBT first became popular here in the UK, that it was shiny and glittering and it was the gold standard, and therefore the effect that therapists had with CBT was due to the placebo effect. Now I'm going to argue that that's not the case. I'm going to argue that CBT is an effective intervention and it can be even more effective so that we can increase the recovery rates and ultimately make more people better. Now, I'm very privileged to have a very exciting data set at my fingertips. So as Chief Clinical Officer at IESO Digital Health, I can do something that I've never been able to do in my career as a CBT therapist, a manager, a lecturer, a supervisor. I'm actually able for the first time to really understand what therapists are doing in the therapy room. So we have a vast data set. Not only do we have the clinical outcomes in terms of recovery and reliable improvement, the patient experience questionnaires, engagement data. This is common data that many services now have, particularly, of course, within IAPT. But we have something that's far more exciting than that. We have the therapy transcripts of over 14,000 completed cases of people that present with an Axis 1 disorder. This is a game changer because we're able to drill down into the therapy transcripts and understand what is it that the therapists who are delivering this intervention, we've got 500 BABCP accredited therapists, what are they doing that makes a difference? So here on this slide you can see an example of how we deliver CBT online using written communication. So our therapists and our patients don't see each other and they don't speak to each other. They communicate by writing. So we're using typed synchronous communication. So patients and therapists are reading and writing. To all intents and purposes, what's going on in that session is absolutely identical to face-to-face CBT. We're not using modular materials, we're not using web-based disorder-specific materials. We are delivering CBT per protocol in an idiosyncratic way. It's just that the medium is a bit different. And I can tell you with pride that the clinical outcomes for delivering CBT using this method are absolutely identical to face-to-face CBT, so this works. So we did an efficacy study in 2009 which demonstrated that this method has efficacy. But I think what's more important than that is now in 2017, with over 14,000 patients, we have effectiveness data. And that, I think, is something that's far more important. We know, because we have to publish our data in the public domain, that this method is equally as effective as face-to-face. And I'm here saying that actually, rather than being a panacea, that this isn't something that I think that should replace face-to-face. What I want is that every patient in England has a choice whether they have CBT face-to-face or CBT online. So something really important happens when you put a computer between a patient and a therapist. What actually happens is that we have a standing research platform. So we're able to actually ask some very important questions like, how do you increase the recovery rate for patients with anxiety and depression so more people can benefit and more people can get better? We have very interesting data sets. So the slide that you see before you is an example of our dashboard. So of the 500 therapists that are working with us, each one of those has a data dashboard. And that tells us, what is that therapist really good at doing? Are they more effective at treating one disorder rather than another? And one of the things I care passionately about is that I want the therapists that work with our service to be the very best therapists they can be. Because that's the only way I foresee that we're actually going to make a difference in this important work that we do. So we're using this data in a very supportive and enabling way by asking our therapists and using our data to say, what are you really good at and what can we help you do better? Now, over the last 3 or 4 years, I've been doing quite a lot of research. So with that many therapists treating that many patients, I asked myself, what is it that the therapists who get consistently good outcomes, 60%, 70% above in terms of recovery rate, what are these therapists doing that's making a difference? And conversely, the therapists who are in the bottom 10%, and I'm sorry about the pejorative language, but the therapists who aren't doing so well, what are they doing that means that they're consistently not getting very good recovery rates? And we've got some very interesting data. There's a very, very strong theme of the therapists who are at the top and getting really great recovery rates. They're doing 3 things. Does anybody have any idea what those 3 things are? So I'll tell you. One is that these therapists have fidelity to the CBT model. They are delivering CBT and not something else. And we can measure that using a tool called the CTSR, the Cognitive Therapy Scale Revised. And this is a validated tool that assesses fidelity to the CBT model. So they score very highly on that consistently. They also adhere to the evidence base. They are using disorder-specific treatment protocols to treat patients, and they stick to those protocols. The third thing is slightly more subjective. They are scientist practitioners. That means they are reflective, they're generally quite critical and humble, they are hungry to learn, and they learn from every single patient they treat by reflecting on that, seeking guidance, going to CPD events, seeking supervision. So they want to get better and better at what they do. Now, the people who were unfortunately not getting such good results, they were doing none of the above. And the interesting thing here is, with 500 therapists, about 90% of the therapists that are working with us to deliver treatment within the NHS, within IAPT, about 90% of these therapists are working within IAPT as well. So it's a very representative group. So it's large numbers and quite representative of the therapists who are out there treating patients within the NHS. So this is really interesting stuff. The second thing that we're doing is that we are now looking at 100 therapists who have the highest caseload, and we are trying to quantify their effectiveness. And we're doing this with something that I've called the IESO equation. So this is a way of quantifying clinical effectiveness within an IAP setting. So we're looking at doing several CTSRs, looking at adherence to evidence-based protocols and stepping back and asking ourselves, do these people display the qualities of a scientist practitioner? And one of the things that we're beginning to notice as we look at not the top and the bottom end, a real spread, is something very, very interesting. So what we're beginning to see is probably about 80% of these therapists are displaying significant drift away from the CBT model and significant drift away from the evidence-based. And that's problematic. And I think, and it's a Sarah Bater hypothesis, I think that's why people like The Guardian are saying that CBT has lost its effectiveness. It's a bit like, when we learn to drive, we learn how to pass the test. We know how to pass the steering wheel between our hands and when we should be looking at mirrors. But when we've passed our test and no one's staring over our shoulders and assessing and examining us, we start to do all sorts of stuff. And therapists are exactly the same. And those of you that know the literature will know that lots and lots of people are suggesting and hypothesizing that the reason why we're not being able to replicate the RCT data in CBT is because therapists drift away from the model. And if you're doing an RCT, you make damn sure that your therapists are delivering whatever it is that you want to deliver. But managers of services aren't able to actually understand what therapists are doing in the therapy room. Going back to this idea of being a scientist practitioner, some of you may not be familiar with the term scientist practitioner. And one of the things that I've observed, both amongst our 500 therapists, but also in my time of teaching and supervising clinicians in a number of universities, is that being a scientist practitioner, I think, is crucial. So a scientist practitioner displays these qualities. They're curious, hungry for information. They're very reflective, both in action and on action, so after they've completed treatment. And they tend to be very humble people who tend to think that they're not very good. And one of the things that I've noticed is that if a clinician displays these qualities, that what happens is that they've got very firm foundations on which they're able to learn, so that the building blocks of learning get taller and taller and taller because they're built on firm foundations. And conversely, if a person is not a scientist practitioner, that actually those firm foundations are not solid, and therefore what you're building doesn't get as tall, so they don't get better and better and better. And I think that this has implications for universities in how we select the clinicians of the future, because I think that if we can get better at assessing, is this person a scientist practitioner, in which case we can build and get them better and better. They will learn and they will really make a difference out there. This is another way of increasing the quality of the treatments that we provide. So you might have seen in a couple of slides ago that I talked about the 8-stage model. This is another invention, for want of a better word, based on our observations. So as we looked at a number, I think probably about over 4,000 completed cases, and we began to look at when the outcome of therapy is not very good, what's happening, what's going wrong? So I've already mentioned therapist drift is one issue. But there are 8 stages where therapy can go wrong. And the first stage is the assessment stage. It's kind of not surprising, it's not rocket science. So if the clinician is assessing a patient and they come up with the wrong primary presenting problem, they're going to be treating the wrong thing. It's a bit like treating somebody for a cold when actually they've got meningitis. The outcome is not going to be very good. So actually helping clinicians to come up with the right primary presenting problem, to consider a differential diagnosis, could it be something else, to use the right measurement tools is absolutely essential. The next stage is actually thinking about, well, what disorder-specific treatment protocol do I use for that disorder? Because remember, adherence to the evidence base is absolutely essential if we're to get good outcomes. So picking the right protocol, and then more importantly, is sticking to it. So time and time again, particularly in patients who have depression, what we see therapists doing is something that I call the scattergun approach. So rather than sticking to a protocol to the bitter end and working through that with somebody, they're actually trying a bit of this and a bit of that and a bit of the other. And when patients do that, the outcome is always poor. This next stage, so the 6th stage, is a collaborative review with a patient. So actually round about session 4, working with the patient and asking the question, are you finding this helpful? Is this moving you towards your goals? Are you starting to see some benefits? Or actually, is this not really for you? It's not the right time to have therapy. It's a chance to really reflect and think about, am I doing a really useful piece of work here? Or do I need to seek help to make it a more effective piece of work? Or actually, is this not really working, and why? And then as we move towards the end of therapy, it's really helping a person prepare to end therapy and to take the learning that has been derived from the therapy session and use that to maintain the gains. And lastly, the 8th stage is back to the scientist practitioner principle. So it's getting the therapist to reflect on every single patient that they have worked with and to use that experience to learn and to become a better therapist. So we're taking all of this information that we have, all of this learning, and in order to enable therapists to be the very best they can be on our site by creating a therapist assistant. So we're using AI and our AI scientists not to be patient-facing, but to be therapist-facing, to enable therapists directly in action to gain from our insight and learning, so that we can help therapists when they drift away from the model, so we can help therapists when they're not recognizing that their patient isn't engaging, and we can help therapists recognize risk. So this is really exciting, and this is where it becomes a game changer, not for IESO, but for all patients, for all CBT therapists, because we are able to actually ask some really important questions. So our research going forward in 2018 is looking at how do we push up the recovery rates for patients with depression, and what are the most effective change mechanisms that we should be using in order to help more people get better. And this is what I mean when I say this is a game changer. Having such a huge data set, such a large cohort of therapists, we're actually able to use the platform because we have the transcripts, we can see and test what's working and what's not working to really derive that learning and really focus on doing something that's really important. So my argument therefore is CBT is just as effective as it has ever been. It's just that we need to help therapists avoid therapist drift, and we need to get them to adhere to the evidence base. And then the world is our oyster. And we are not going to rest on our laurels. We want to push the recovery rates up time and time again so that more and more people get better. Thank you.
Thank you very much, and kept beautifully to time as well, which gives us a moment for any questions that anyone has for Sarah. Yes, we've got a hand just over there, and I don't know that the microphones are here, so you may have to speak very loudly.
I think you're absolutely right. So one of the things that we're seeing, that we're working with some therapists in America, and I was very naive and thought that CBT was born in America, so therefore the therapists there are going to be super duper great. They're not, and it's because of exactly that issue. So a person may have gone to a workshop, a week's course, and they call themselves a CBT therapist. And actually, when you look at what they're doing person-centered counselling, something very, very different. And what is emerging from our database, and one of the things that's really exciting, is that if somebody adheres to a protocol, and that protocol has an evidence base, the person will get better. So there are people who are in America who actually they're creating simpler protocols where they're able to train people to deliver an intervention with very little training, but it's all about adhering to the evidence base. Whatever the protocol is, if there's an evidence base for it, it will work.
Okay, we've got two more questions, so we're doing well. We've got one right at the back and then one towards the middle. So yes, and we don't have mics, so if you can speak as loud as you can, and apologies for that. Yeah. Yeah, so with such large numbers of patients going through the service, one of the things that we do as a routine is ask every single patient about their experience. And we also regularly ask everyone, would you like to be more involved with us, because we want to learn from your learning. This is a collaborative process that we're engaging in, and that means working together in order to get there, to make more people better. So we're asking people whether they can help us, tell us about their experience, how we could make it better, what worked particularly well for them, what was it that their therapist did that made the difference, because that's crucial as well. It's not just about outcome measures, what the data says, it's also about, what people say from their own experience. So we embrace that. I mean, that's really encouraging. We have lots of discussions about co-production and there's lots of exciting work going on. I haven't seen much of it in the IAPT field, so it's good to hear that, and I'm sure there's more out there than I know about. Got time for one more, and then we're going to move on to the next presentation. So you were first, so yeah.
Yeah, it's a really good question. So I could only cram so much into my 20 minutes, but actually we looked at a number of variables. So we took those therapists that we examined, and we looked at their core profession, their age, the amount of experience that they had, the university that they trained at, and their gender. And we made sure that there wasn't any other variable that would account for the difference, and actually there isn't. So there is some literature out there that would suggest that the higher your academic qualification, i.e. if you've got a PhD or a clinical psychologist, you're going to get better outcomes than somebody who has a master's, or just you'd only be a CBT therapist if you had a postgraduate qualification, but that isn't the case. It doesn't matter, and it actually doesn't matter how experienced you are either, whether you're 1 year post-qualification or 20 years post-qualification. It has everything to do with whether you're doing what you were trained to do.
Great. Thank you very much, Sarah, and thank you for a fantastic presentation as well, and some great questions around that. So brilliant stuff. We're absolutely bang on time. That's good, isn't it? Final presentation before lunchtime, and I'm really grateful to Andy Rooney. He has stepped in at very last minute when a colleague is unwell. So really grateful you're here from Endzone, and the floor is yours. Thank you. And no jokes about Rooney coming on as a substitute, please.
It's my opening gag.
Oh, sorry.
Okay, good afternoon. I'll take my glasses off. So thank you very much. Hopefully you'll sort of understand the position I'm in, really, and that some of you might be thinking, thank God it's not me in your position. Just hold that thought. So if I do stumble over some slides, just hold that, and you can empathise with me. Okay, so what's the case study about, the case presentation about? I'd really like to tell you about Couth, which is our Endzones online counselling support platform. particularly to tell you about our model, our service delivery, and really to focus on 3 core elements really, around reducing stigma, increasing access and improving outcomes. A little bit about Zone. Okay, what's Zone's purpose? Well, essentially, Zone as a company, our aim is very simple. It's to make it easy and safe for all generations to access the best emotional and mental health services as and when they need them. And I think that's really crucial, I think, because we're talking about accessibility. And we've heard this morning about the tendency to pathologise, and I think sometimes there has to be a problem before young people can access services. And I know people within the room will be very much aware of the value and the work you do on a day-to-day basis. I'm sure for a majority of you is, okay, how can we increase access and provide that early level of support? Well, that's what we do, really, and that's what Couth does, essentially. So how do we do that? We do that through tech. So we're a tech company, but we're more than a tech company. Our roots are also in providing an effective and robust service delivery model around supporting young people. Just a few stats, essentially. Our Couth platform, as it currently stands, a young person logs in every 90 seconds. That's during the waking hours, not during the middle of the night. And also we are currently contracted to deliver to 46 local authorities and CCG areas. The actual total number of CCGs, we're covering about a third of all the CCGs in the UK at the moment, because some of those contracts are with multiple CCGs. So we've been up and running since 2004 as Couth. We've iteratively developed our service over that time, and we're now in a position really where we can begin to report very, very comfortably on how we're helping to help young people access support and advice, and if they want it, counselling, and also just to generally raise awareness of the value and begin to prove the value of a digital offer to support the services that are available. It's just a map to prove where we are at the moment. So this actually is a little bit out of date. The shaded areas are where we are delivering Couth currently at the moment, where we are commissioned. But actually that's up until end of April this year. There are some new additions to that area. We can shade Kent now. We've just recently been commissioned to provide Couth under the Head Start programme, and hot off the press you can also shade in Essex as well, where we've just been asked to provide Couth to the 7 CCG areas in Essex, and we're mobilising currently. Okay, that's where we are as a young person. There's a young person there. So digital is at the heart of what we do. Why? Because young people are digital natives. That's why we know digital has a really, really important role to play in supporting young people. We have a deep-rooted philosophy around co-production. Our site, the development, the look, the feel of our site has been informed through the views and thoughts of young people and the contribution. And in the day-to-day running of our service, the content and the way that the themes and the content feed is influenced by our young people. Young people participate in the content that goes onto our particular site. So, yeah, that's the value of digital. We know young people are digital natives. I must stress at this point that we would not be as successful as we have been, and I don't think we would have seen the movement of young people using our Couth site if we didn't work collectively and proactively with local providers. Digital would not work on its own. We have to blend, to use that word, with other services as well. So we make that a big part of our Couth offer. We simply work where we are commissioned. We work with all local providers, be they the voluntary sector, be they existing universal and targeted services, but also very closely with our secondary care colleagues in those particular areas, really to ensure robust and seamless pathways. So that's core to what we do. That's what our site looks like. There you have it. Young people very simply are able to sign up and log into Couth. They can access, the site itself is 24/7, 365 days a year. So there's 24/7 self-help material on the site, so it's a multi-channel platform. Self-help's a big feature. peer-to-peer but moderated support is a key feature. That allows young people to communicate with each other, use particular issues and themes which are relevant and important at that time. Our back-end team are very, very proactive and obviously for obvious reasons moderate all content, so there is no direct peer-to-peer support. And that's a really valuable approach, I think, to help improving accessibility. That's the feedback we get. They can talk to each other through a moderated platform. So that's something we are, is core to our delivery. In terms of accessing counselling support, that is also available. Our availability for counselling, as you can see there, runs from 12 p.m. 12 midday to 10 p.m. at night. Weekends, it's 6 to 10. So that allows a young person to drop in for a chat with our BACP accredited counsellors. And obviously it's short for time now, but I can certainly let you know more about our clinical team in the break, but I'll touch on it a little bit more at this point. So our young people are able to drop in to access our counselling team. Very simply, if a young person chooses to do that, they would be offered a baseline triage assessment. We use YP Core as one of our measures to measure need and well-being. And essentially, that allows a conversation and a discourse to continue. So that's a primary aim and a primary route for young people to seek early intervention or get advice or get support through our counselling service. A bit more about what it looks like. So young people can also use it, they can also access Kooth via smartphones. We've recently invested in allowing our platform to be far more compatible and smartphone savvy. We are seeing an increase in use of our service through that. So again, it's of how to improve accessibility or give it to them on their fingertips. So that's really, really helping. Another young person. Always like these quotes, so just have a read of that, really. So the value of tech in allowing choice around how young people access mental health services. Tech isn't for everybody, as indeed face-to-face isn't for everybody, so it goes back to that blend. It's really, really important we give young people that choice, and that's a principle we hold really, really dear at Zenzo and also in terms of how our Kooth platform is developed. A few stats. I think I'd just sort of probably highlight the number of logins, really. So this is over a year. This is again about how young people access advice and support. So by logging into Kooth, so we've got just over 230,000 logins in 1 year to Kooth. New registration, so whenever we go to a new area, we invite young people to sign up and register. So again, in the last year, just a tad over 40,000 new registrations. So young people curious, wanted to suss out and maybe even use Kooth. Stigma, the other area, so it's about reducing stigma. And again, a quote from one of our young people. So Kooth has really helped me. It's given me relief when I've had nobody else to turn to. Thanks so much for talking to me. So that's within the context of really perhaps not being able to find the way, or maybe feeling sort of stigmatised by not being able to access support or even ask for help. How do we do that? I think, again, the tech offer provides that choice. So you don't have to speak to a person about that. The other thing just to sort of highlight, and I think it's crucial to understanding Kooth, is that young people at the point of entry sign up anonymously. So there's no patient identifiable data, to use health terms. Now, I come from the health, my background is within the health service. I left as a psychiatric nurse. I left probably about 7-8 years ago. Everything was around patient identifiable data. This is a real shift. Anonymity is great. It's clinically managed very robustly by our very experienced and dedicated clinical governance team. We have a clinical director who manages the obvious questions around safeguarding, and if we have time, I'm sure one of you might want to ask that question afterwards. But we certainly make sure that any young people who then present with a level of risk are able to, we work with them to sort of highlight the risk that we are concerned about, and also to be able to think about how they can give us consent to give them their name so that we can link them into the existing pathways that we establish within each particular contracted area. So reducing stigma. Very simply, young people find the online environment safe and feel less exposed. And that's from that specific report, Manchester University, comparing online and face-to-face student counselling. So have a read of that. I think that helps you sort of set the context of online and face-to-face. I'm now going to talk about Thrive. Who's familiar with Thrive in the room? Scattering of people. A lot of noise, a lot of buzz around Thrive at the moment. So I guess in terms of children and young people's emotional health and well-being, thankfully we're moving away from that ridiculous tiered model, and we're now looking at something that actually young people, the majority of young people thrive, but they have various levels of needs which can peak and reduce at specific times. So I just really wanted to make the point that the Kooth model mirrors perfectly the Thrive model, in that the various functions on the site allow a young person to get advice if they need it, through some self-help forums or through some self-help material, or if they want to access more help, get more help, they can tap into our counselling service. We inevitably work with young people who require more help, and we do work with young people with very complex needs, but that's where it's important that we do then integrate with our partners in local areas to make sure that the pathways are clear, the support is right. As a service, we're not necessarily the lead at that point, but we would work to support existing work that's being delivered, or maybe work that's needed, and the support that's needed for that particular young person. So what's the digital advantage? Instant professional support for children and young people whenever they need it. Reduce waiting times for CAM services. Reduce waiting lists, potentially. Reduce pressure on GPs and A&E departments and hospitals, and reduce pressure on specialist services. You know, that's not rocket science, that's what a good early intervention model should do. The key points I've mentioned, it's integrated and it offers choice. And it's crucial, tech is crucial as part of an early intervention service. Future in mind, very clear, we need to make better use of the voluntary and digital services to fill the gaps in a fragmented system. We've spoken a lot about that this morning. Online counselling has the potential to provide an important support system for issues that might otherwise remain unexplored. I think that again states the obvious. It's that choice element, it increases access. Okay, how good are we? What are our outcomes? And I think that's something we are developing significantly over the years of the iterative developments of Kooth over the time. So how do we measure outcomes? As part of a core triage, as it were, if a young person chooses to drop in to use Kooth, our counsellors would use YP Core. Really, that allows a conversation to take place, and it also allows us to screen need. And also part of the risk assessment process as well. We don't report a YP Core, but we use that as an initial assessment tool. We're a goal-based outcome service. I think like a lot of universal and targeted services, we really value and work with what young people want to work with. Their goals are crucial. We work with the goals that they particularly want. So we have developed our own specific measure, really, which is called the Counselling Goal Systems, or COGS for short. It's very simply a distance measure tool, distance travelled tool. Goals are created by the young people, very much supported by the counsellor, and regularly updated on a scale of 1 to 10. And we work with those goals throughout their therapeutic journey with Kooth. And just also the recent development, whereas before we were setting goals within the context of chat, our live text chat messaging, we've now shifted that young people can set goals outside of chat. So if they're accessing the site for some self-help materials, or maybe they're participating in forums with other young people, they can set goals around some of the content that they're exploring and they're wishing to work on there. So it's a way of taking that distance travelled outside of a one-to-one intervention. We also use end-of-session questionnaires, simply follows the CYPI requirement for capturing really the therapeutic alliance. And I'll come on and I'll show you a slide about that in a second. We also have evaluation questionnaires as well to say, can you give us some feedback on what you think about the site? So we also give the young people the opportunity to comment and rate us on that particular level. And just an aside that we do our own sort of friends and family test, really. Would you recommend to a friend? And the majority of our contracts, it's around about 90 to 95% of young people would recommend. A little bit about goals achieved. So as I explained, essentially, young people set a goal and it's on a rating scale of 1 to 10. I just really want to highlight that over the period of Kuth's life, young people have set around about 5,000 goals in that particular, over that time. And in the majority of cases, as you can see, 52% fully achieve the goals that they have set out to achieve. So essentially, just over 2,000 young people have fully achieved the goals that they wish to achieve. I think this is a useful guide, really. And again, I think it just highlights what young people might want from mental health support, emotional wellbeing support. Manchester Uni helped us code the types of goals that young people set themselves, really. And I think just to sort of look at that particular graphic there, really. 1 to 3, it's really about getting help. The majority of young people who access Kuth actually just want to get help. And how can they seek help? How can they get advice? So those are the top 3 in terms of goals set by young people. So that's really interesting about where do we invest? What do we think about in terms of should we be focusing at the sharp end, the complex needs end? There's an argument for that, of course there is, but equally I think we're saying that potentially, and I think what our evidence is beginning to show, is that it is definitely worth investing at the early intervention end, simply because a lot of young people have set goals, but all I really wanted was how do I get into a service, how do I understand how I feel, and how can I sort of find my own support and my own self-help and my own guidance around that. And the next area is just more about sort of obviously tapping into more specific therapeutic support. So those are the most common types of goals that young people highlight on Kuth. A little bit there about this is the graphic in the middle is what young people see after they finish the chat session. They're asked to rate how it went, and those are the Therapeutic Alliance questions and the measures that we regularly report to our commissioners. And as you can see, we're pleased to report that in all of the cases, we're looking at certainly over 75% see the rate as highly in terms of feeling understood, and also talking about what was important to them. Was the service a good fit for them, and was it right for me? So we report on those regularly. Final point, really, here is we know it's a good model for young people. Young people have bought into it. The volume of young people have bought into a digital model to ask for help and to seek early support. But what's the impact on the system? And we've sort of highlighted that here, really, that there is some evidence that we're certainly from our commission in Bracknell Forest, that since the introduction of Kuth, there's been a 7% reduction in referrals to specialist child and adolescent mental health services. Biggie in Lincolnshire, we were very much integrated with the primary mental health service, and there was a significant reduction in inappropriate referrals to specialist CAMs from 35% to 2%. That's very much working with a local partner. A lot of commissioners say actually what we're seeing is a lot less noise in the system. It's less buzzy. I think people are clearer about the pathways. But this is where there's a lot of work to be done, really. And I think we certainly at Zen Zone, we're desperate to work with commissioners, secondary care providers to really focus on the impact upon secondary care and the impact upon, I guess, the longer term outcomes for young people. So that's a plea really to say, look, we've started, but we would really, really like to work more and sort of drill into that a little bit more. And in fact, we've been working with the Education Policy Institute around outcomes and impact, and their report is due to be published at the end of October. So you're more than welcome to download that paper. There's a link on our website to do so. So in a nutshell, that's Kuth. A few more comments. leave you with that. Thank you very much.
So before I've even requested, a hand has gone up. Goodness me. We don't have very long. It is nearly lunchtime, so I'll just take the one I saw first, and it was you, yes. Then we'll have our instructions for later. So please, I think a microphone is coming. You don't have to shout.
Hi, my name's Kate Thackeray. I'm from the University of Worcester, a lecturer in youth and community work, so I'm really interested in what you're saying there, and really welcome to hear what's going on. So just two questions, or 2 points of information, really. One is, what's your definition of a young person in relation to this digital world? And the other one is, what's the profile of the professionals that are supporting the young people that actually are in contact with you, just out of interest?
Thank you for highlighting the bigger mission. What's the age range we work with? So for Keith, the majority of our contracts are 11 to 19th birthday. So it's adolescents, those attending secondary school, or if they're in further education, then so. But we also obviously make the service available to those that aren't in education or employment. Some of our commissioners, and we're really pleased to see this, our commissioners up to 26th birthday as well. So we run from 11 to 25 effectively. And for all of the transition challenges that we face within young people's mental health, we're a big, we promote that massively, and so we do go up to 26th birthday in some of our contracts. And the profile of the, sorry, your second question, the profile of the professionals?
The profile of the professionals that support the young people that engage with you.
Oh, it varies. I think certainly if we look at an early intervention model, the vast majority who are at the sort of the advice and the getting help stage, if they are being supported outside of Youth, which inevitably they are, it's usually within school. And I didn't go on to say, really, because we didn't have the time, about our school in-reach programme, because we promote Youth to young people through a very proactive in-reach programme into schools. So schools primarily. It could be local face-to-face services, GPs inevitably as well, but also I think if we get into the more complex level of needs, and very frequent for us, and it's a core business in a way to also work with CAM services and social care.
Great, thank you. I think we've come to the end of our morning. I can hear tummies rumbling. So thank you so much for a fantastic morning. Some brilliant questions. Sorry we haven't had time for more, but I think both Sarah and Andy are around, are you? For any further discussions that you want to have. When we return, it's 2:00. Nice long time for lunch. Thank you, Rob. I think there's concurrent sessions, isn't there? Will there be information about where to go?
It'll be handed out at lunch.
Great. So you will be directed to where to go to whichever session you want to go to at 2:00. So really just huge thanks to Sarah and Andy for two terrific presentations before our lunch.